All right. Hello, everyone, and welcome to today's Rafael Medina subspecialty VMR. I'm super excited for today's session. For those who don't know me, I'm Elena, and I'm a not anymore medical student, but graduate from Germany. And so today we have a clinical reasoning subspecialty VMR, which I'm super excited for. And I'm thrilled to be joined by Verity Schaye and Olivia Liu today. So Verity Schaye is, to me, a very inspiring educator and associate professor of medicine at NYU Grossman School of Medicine, where she practices as a hospitalist at Bellevue Hospital. And I think she's a perfect guest for our session today. And yeah, why don't you say hi and tell us a little bit about yourself, what you like to do in medicine, but also outside of medicine.
Hello, everyone. Thanks for having me. I'm a big fan of this podcast, so feelings mutual. Honored to be a guest. So as Elena mentioned, I'm a hospitalist, so in inpatient medicine, adult inpatient medicine, because there are pediatric hospitalists as well, of course. And passionate about clinical reasoning, and really do a lot of focus in education research and teaching and assessment in clinical reasoning and how we think and make decisions. Outside of work, I'm an avid traveler. I actually just got back a few weeks ago from Antarctica, which was the most amazing trip of a lifetime. So we could just pivot and have this be a slideshow instead if you want. And I have lots of photos of penguins.
Yeah, that sounds amazing. What did you like about Antarctica?
Very humbling. I think just like the
Mm.
vast landscapes of it. I mean, just magically beautiful, but very humbling. Not a, maybe I can vote not opposed to pivot to talking Antarctica.
Yeah, I'll keep track of the chat, what we end up voting for. Um, so Verity, I know that you're very involved, in like clinical reasoning, and I know that we're joined by many also like young learners. And I think I would be just curious, kind of what you would tell yourself at the stage of some of the people that are in right now concerning this.
I think that kind of the biggest, most important thing is having a growth mindset. We are all lifelong learners. I mean, that's what this podcast is about, right? Like, constantly kind of learning and growing, and no matter what stage of your career you're at. So, certainly as a faculty member for, however many years, over a decade now, right? But whatever stage you're at, and I know that's easier said than done when you're at different levels of training and being assessed and some of the pressures that brings. But we are all, that's the joy of what we do, is we're constantly learning and growing and knowing what questions to ask, right? And knowing how to find those answers. We never know all the answers, right? And obviously with the pace of change of medicine, it's constantly evolving too. So I would say those are, and obviously this podcast is one big way that you can continue, obviously lots of other ways as well, but a way that you can do that.
Yeah, I feel like just by the fact that you all are here today, speaks to how committed to growing and learning you all are. I think some other thing that I found to be, helpful is this relationship of like mentoring and mentee. Is there any advice you can give us on that?
Absolutely, yeah, absolutely. Mentorship, coaching, sponsorship, all slightly different things. But again, finding your people, if you will, in your certainly, your academic life, but also your personal life. Sometimes those things cross over. And also, I think you'll have multiple people that serve different roles, right? So you might not have one mentor that serves a kind of all roles, and some of it might be kind of different aspects. And I think certainly, with a lot of more, junior folks here that might still be more in the mentee relationship, granted many of you, I'm sure, mentors as well, is, how to be a good mentee and sort of be present and come with questions to your mentors and be prepared for those discussions and meetings. And I think there's also skills of being a good mentee, obviously of being a good mentor as well.
Yeah, thank you so much. All right, so for our case presenter today, we have Olivia Liu. She's a medical student at NYU Grossman School of Medicine, but also doing a master's right now. And I would be just curious, how is life as a med student in New York, and what do you like to do outside of medicine, and where do you want to go?
Yes. Hi, my name is Olivia. It's nice to see everyone. Being a medical student at NYU is fantastic. I think we have wonderful mentors and wonderful clinical instructors. And I think it's also such an honor to serve the patients that we get to serve. We serve a really diverse patient population and also treat patients at Bellevue Hospital, which is the nation's oldest public hospital. And it truly is an honor to be able to work with those patients, to serve them and to learn from them. And as you said, right now I'm doing a master's. I'm pursuing a master's in health policy and management with NYU's Wagner School of Public Service. So I'm taking a year in between my third and my fourth year to complete this. And outside of being a medical student, I really love to dance. Currently, I dance a lot of salsa. So that's what I love to do in my free time right now.
This sounds absolutely wonderful. Um, and last but not least, I would be curious, and either of you can respond. How do you know each other? And maybe there's an experience that you had together that you might want to share.
Olivia, you want to take it or you want?
Yeah, I can jump in. So I serve right now as the clerkship liaison for the medicine clerkship. And what that means is I am a student who's already completed my medicine clerkship and my core clerkships. And now I serve as a liaison between the current students and the faculty who are part of the medicine department. And so that's how I know Dr. Schaye, and that's how we've worked together in the past.
All right.
I would just add as well, I mean, again, of also all the trainees on here of like the importance of the trainee voice and building curriculum and input and feedback. And it's been wonderful to get to work with Olivia in this role.
Awesome. That sounds great. Thank you both so much. All right. Last but not least, I would like to thank our two Academy members who are making the session possible today, Rahul and Masa, who are doing scribing and teaching points and taking care of the whiteboard so everybody can keep up. Rahul, do you want to say a quick hi?
Yeah, sure. Hello, hi everybody. Good morning, good evening. I'm Rahul. I'm an international medical graduate from India and applied for the math cycle. And I'm excited for the March. And thank you so much for having a thank you so much. And I'm excited for the case today.
Yeah, super excited to have you, Rahul. Rahul is a big nerd on hematology, but all the internal medicine fields. Masa, do you want to say hi?
Hey everyone, I'm Masa. I'm Syrian based in Dubai. And yeah, I'm really excited to see what you have in store for us, Olivia. Thank you for coming and sharing the case.
Yeah, Masa, super exciting for your always brilliant teaching points. And we are both happy that we can attend today because of time differences. All right, so the whiteboard is up, and Olivia, whenever you're ready, you can start with the first aliquot.
That sounds great. Thank you so much, everyone. So for our chief complaint, we have a 32-year-old male with diarrhea for 3 weeks. The patient has a history of irritable bowel syndrome diagnosed 3 years ago. He was in his baseline state of health of having occasional abdominal cramping, specifically after eating, until about 3 weeks ago when he developed diarrhea and diffuse abdominal discomfort. The patient stated that 3 weeks ago, he ate a turkey sandwich from a deli, which he had left out on his kitchen counter for a few hours before eating it. 2 days later, after eating this turkey sandwich, he started having diarrhea and this diffuse, constant abdominal pain. The patient stated that normally he has about 2 to 3 formed bowel movements per day during waking hours. Now he was having 4 to 5 bowel movements of diarrhea per day, and he was also having these bowel movements at night and was woken up 1 to 2 times per night because of this diarrhea. He describes that the diarrhea was loose, brown, and malodorous. He didn't notice any mucus or blood in his stool. He also had diffuse constant abdominal pain during this time, unrelated to his eating. These symptoms, the diarrhea and the abdominal pain, continued for about 2.5 weeks. Then, 2 days prior to presenting to the hospital, his symptoms started to worsen. He was now having bowel movements about 3 to 5 times per hour. He also started feeling nauseous and weak. He described having decreased appetite, though he was able to tolerate oral intake. He didn't have any vomiting, hematochezia, or melena during this time. Then, one day prior to presentation, he started to feel feverish, though he didn't take his temperature at home at the time. The next day, he decided to go to the emergency department. Of note, he reported about 15 pounds of unintentional weight loss over the past 3 months, and he also endorsed traveling to Paris and London 2 months prior to the presentation. He denied drinking any contaminated or dirty water on his trips or swimming in any natural reservoirs or lakes on his trips or since coming back.
Is this a good place to stop?
Yes.
Okay, perfect. Yeah, I want to start to this case. A lot of information and a lot of characteristics about the diarrhea that the patient is having. And I feel like before we jump into the acute presentation, I think I would just be curious because there are many patients who carry the diagnosis of irritable bowel syndrome. How do we make that kind of diagnosis, and what are the circumstances when we deviate from that diagnosis?
Yeah, I'm assuming that's for me. The question's for me. Yeah. Okay. Just making sure. Yeah. So, and I think that's some of the questions I have about this case of like what his symptoms were before this 3-week period and how he came to the diagnosis of IBS. Because I think what my mind immediately, and I will answer your question, but that's a little bit of circuitous route of getting to it. Of just related to how I'm thinking about this case in context is the time course of the current illness. And is this subacute 3-week course, or is this an acute progression of something that's more a chronic disease? And was it IBS or was it something else, what his chronic GI illness is? And so I would be curious of what some of his symptoms are. And there are, Rome criteria, and I honestly couldn't stop what all of them are off the top of my head of what the Rome criteria for diagnosing IBS, and then something I would definitely just pull up on my phone to kind of go through. But there are specific criteria, and certainly ruling out other diagnoses, whether it be obviously inflammatory bowel disease or usually obviously things that are cause more chronic illness, because there are some infections that will cause more subacute to chronic illnesses, which we will get into in the context of this case. So I would be very curious of how he came to that diagnosis in the first place as it relates into also how I'm thinking about this case.
Yeah, fantastic. I think I have I have some similar thoughts on this for sure. And now coming to the subacute, maybe even chronic presentation that the patient is having now, I feel like so what I have learned is that with acute diarrhea, we often don't even make this intellectual effort, to like think of mechanisms and all of that, because they're often self-resolving and often due to, viral infections or medications. But how do you approach the complaint with this kind of chronicity that Olivia presented?
Yeah, because we're a little bit in the in-between zone with this case, and that's why again so we're certainly past the acute phase, right, at 3 weeks. So we're not quite yet at I mean, it's just about usually technically 4 weeks is what we call chronic. And so and some of it depends on, which we haven't heard yet, the immune status of this patient, because that will totally change of acute things can become chronic because they can't, don't have the immune system to fight off infections. So some things that we would normally think in the acute paradigm also would be in this time course as well. And so that's something that's going to be a big thing that comes into play for this patient. What their immune status is will make me think about differently of, am I still activating a little bit my acute diarrhea paradigm? And so I think I'm going to be going to both schemas for right now, since we're in that in-between time course of still thinking about acute diarrhea. And the biggest thing in acute diarrhea is infections. I mean, there are other things that cause acute diarrhea, but that's the biggest thing we'll be thinking about. And then certainly thinking about is this just the beginning of a chronic disease course, or is this part of what he's had? And I forget when, I think it was 3 years ago, I forget exactly when the IBS was diagnosed. Like, is this all part of one actual chronic disease course?
All right, fantastic. I think I would be just curious, if you were seeing the patient right now, in the clinic, they report this history of diarrhea. What are some of the questions that you would ask, to like get a sense of what is going on? What are the red flags? Do I have to admit this patient, or can I send them home?
Absolutely. So I'll say hypothetically what I would do. I'll say, as for context, I don't work in the clinic, so this is not my day to day, but I definitely will say what hypothetically, because I do hospital-based medicine. So by the time they come to me, someone else has made that decision, which I have so much respect for. But I think the biggest things, again, if you're seeing this patient in the outpatient setting is, yes, can I treat this in the clinic, or is it something that needs inpatient hospitalization? And those big things would be dehydration status. And so we heard that this has definitely escalated over the last 24 48 hours of like the volume of diarrhea and the ability to intake oral intake. And so that's something that's definitely a flag of, does this patient need just IV fluids and supportive care, which obviously would require inpatient hospitalization and likely cannot be accommodated in the clinic. And so some obviously basic labs and renal function, things like that, to look, and yes, physical exam as well for hydration status, blood pressure, to get a sense, orthostatics of volume status in that domain. We heard also about feeling feverish. So again, how if there's any more systemic signs of inflammation and acuity, and things like fever and white count, and both in whether it be on vital signs or initial laboratory data. And so those might be reasons a patient needs to be kind of monitored when we get into thinking about, do they need empiric antibiotics for treating some of these infectious causes? Those are some of the things that'll come into play of, just do we empirically give a course of antibiotics while we're getting more data? Are there any systemic signs of inflammation? And certainly also with going back to the dehydration, certainly electrolyte repletion as well becomes a big important in electrolyte monitoring in these patients. That could require obviously more frequent blood draws and repletion that requires inpatient hospitalization. So those would definitely be some of the things of factoring in, can this be treated here or needs to be in a different clinical setting?
Yeah, thank you so much. So I feel like whenever we suspect, that there could be an inflammatory or even infectious process going on, we love to ask those infectious disease-related questions. We ask for travel history, any unique exposure. And Olivia has shared that the patient has had some travel. I think I would be just curious if that is something that helps you, or that for now just put to the side, or how do you put that into your calculus?
Yes, we heard some very helpful pertinent negatives, which was great. And so, yeah, absolutely. In terms of, we're thinking particularly in the infectious, category of what, travel history, and as I already mentioned, sort of immune status and risk factors specifically what I mean by that, risk factors for HIV will change what types of infections we're thinking about in this patient. And so that's we heard some about the travel history already. We haven't heard about some of the potential risk factors for HIV, which I'm sure will be forthcoming, because that will definitely change potentially when we get into what studies we're going to send, what stool studies, other risk factors for, some parasitic infections, or we heard about water sources and whatnot, and things like giardia. And so sometimes we forget to ask, and obviously I know everyone's coming from all over the world here, and so we are, as I think you already heard, and I'm assuming this case is from one of our hospitals in New York City. I'm just going to make that assumption. Like sometimes when we ask travel, we think of like outside, but we're like, did you just go camping upstate this weekend, right? Or things like that. And sometimes we forget to ask, and that's going to be obviously specific to wherever your local context is. But sometimes when patients hear travel, they think something more distant than just something, or when it comes to like tick-borne illnesses, we're right near or somewhere called Long Island, where there's like tons of, like, and some of our patients live out there, and we don't think to ask those kind of like travel history exposures that are like closer to home, if you will.
Awesome. I think before we jump into the next aliquot, I think I would just like to know, because we've mentioned many differentials right now, what are the big buckets that you think about when a patient potentially has chronic diarrhea that we might go into right now?
Yes, and again, like, right, there's, I think there's like, what schema are we going to activate here? Of like, there's certainly one for acute diarrhea, and then there's one for chronic diarrhea. And I think, specifically in the chronic diarrhea of, thinking about, is this inflammatory? And within that, sort of like the bigger buckets within the, biggest buckets within there are certainly inflammatory bowel disease, and then, infectious causes of, and that, of course, has a very long list, which I feeling we might end up getting further into in terms of specific organisms, in terms of inflammatory. And then, think about if something is more, non-inflammatory bucket. And we heard some interesting things that might kind of help with this is something, kind of more osmotic, and things like, fatty and pancreatic insufficiency, or secretory diarrhea, and which could be also infections kind of can fit in the secretory category as well. We did hear, I think, some data points about like waking up at night for diarrhea, so that might be some clues that it might be in the secretory category of like the awakening from sleep, and this happening in isolation, not like just postprandial, that might kind of direct us towards kind of that bucket of larger buckets in the chronic diarrhea paradigm, if you will.
Awesome. Olivia, I think we're ready for the next aliquot.
Yes. So moving on, his review of systems was otherwise negative. For his past medical history, like I said, he was diagnosed with irritable bowel syndrome in 2021. And at that time, he was having abdominal cramping kind of diffusely and mainly after eating. And he was also having some small volume diarrhea regularly. At this point now, he was having more so just 2 to 3 form bowel movements a day. He also has depression, which was also diagnosed in 2021. He has had no prior surgeries. For his medications, he takes duloxetine 30 milligrams PO daily. For his allergies, he's allergic to ibuprofen and he develops angioedema. And he's also allergic to gadobutril and develops urticaria. As for his family history, both of his parents are alive and well, and he has no siblings. For his social history, he works as an administrator at a testing center. He is single and is not sexually active. He lives with his mother and his 2 pet cats. He doesn't drink alcohol, and he has never smoked or used illicit drugs. I'm just going to take a pause here before I move on to the objective data.
Yeah, I'll just say, kind of comment here. I mean, we heard like some of the things we were thinking about before. Again, a little bit more about his IBS history, which we heard a little bit more about his symptoms. I'd be curious of like, did he have other things, kind of, what other workup he had in the setting that before they kind of got to the diagnosis of IBS. We certainly heard about, sounds like he has no risk factors that we are hearing about for HIV, which is helpful. The other things in terms of with IBS and medications, often those patients can end up being on like PPIs and things like that, that can then put at risk for different change in the gut microbiome, and like changes in terms of risk factors for infections and for bacterial overgrowth and small bowel kind of bacterial overgrowth, which sounds like this patient's not on. So other things that in his history that will potentially inform this patient's differential, or potentially rule things out. And we also heard about animal exposure. I'll add about with the cats. Can't have always have to think about animals in any infectious disease differential.
Okay, so moving on to the vitals. Upon presentation, he had a blood pressure of 108/80. His heart rate was 84. He was afebrile, had a respiratory rate of 18, and his oxygen saturation was 98% on room air. As for his physical exam, for his general appearance, he was a tired-appearing young man who did not appear to be in acute distress. For his head, eyes, ears, nose, and throat exam, He had dry mucous membranes around the mouth. For his cardiovascular and pulmonary exam, these were both normal. For his abdominal exam, he had no abnormal marks or scars on inspection. On auscultation, he had normoactive bowel sounds in all 4 quadrants. On palpation, he did have mild tenderness to palpation diffusely. He had no guarding and no rebound, negative Murphy sign, and a negative McBurney sign. His neurological exam and his MSK exam were normal. So I'm going to pause here for aliquot 2.
Fantastic. Thank you, Olivia. So some new information, a lot of pertinent negatives, a little bit of a soft blood pressure, some tenderness on palpation, and maybe some reduced body mass. Yeah, I think I would just be curious if this helps you in any way or not. Yeah.
I mean, so it helps just again, in a sense, kind of going back to like how sick is he, right? And some of the, acuity and, and inflammatory state. And so we are, we heard about potentially subjective fever. We're not seeing that. Granted, this is, one data point on admission of afebrile, but, not hearing that he's got a fever in terms of that might inform, differential and also management. Obviously those things, we don't necessarily think about them in isolation. We're often thinking about them concurrently. As you mentioned, like, I don't know what his baseline blood pressure is, so maybe this is on the lower side for him, and just, his hydration status. And he does sound like he is a little bit dehydrated just based on some of his other physical exam findings. And it's no guarding and rigidity, right, in terms of the abdominal exam. Okay, just making sure, because I know there's still sort of typing in there. And the, always what's skipping ahead to think about management of, usually you don't necessarily need to jump to get abdominal imaging for these patients. Certainly, if there were guarding and rigidity, would be something that I would then, prompt me, certainly to think about, does this patient need abdominal imaging? But there's no sort of alarm signs, and the diffusely tender is not necessarily going to zone in, if there's just inflammation in the bowel, there, could be that those findings on exam. So not necessarily helpful narrowing things down per se.
All right, great. So I'm assuming that the next thing we're gonna get is the labs, and the patient seems to have had, for quite some time now, this diarrhea. I think from what I can tell, no vomiting. So I think I would just be curious, what are you expecting to see on labs, especially in terms of acid base, but also, in terms of CBC, do you expect inflammation going on, or yeah?
So I won't be surprised if he shows signs of dehydration on his labs, and of whether we see that in the manifestation of metabolic derangements or elevated creatinine, low potassium. So I won't be surprised if we see some of that. We might not necessarily see, I mean, again, we're not seeing necessarily so far like of from an inflammatory state of whether we might see an elevated like peripheral white blood count. If we, kind of jumping ahead, I guess, getting into, this is a patient we would send stool studies on of, again, it's been going on for the, duration of time, 3 weeks of time. We're still going to think about some of the acute infectious things, even though this is a little bit of a long course for a lot of the, the common infectious things, and like the, bacterial infections like the salmonellas and the shigellas. And, we're not also, what's going to be our astute, right? There was, I don't know if we've commented on like the lack of blood. So that's going to be helpful, like thinking less likely, again, some of these, the things that will cause bloody diarrhea. I'm pretty sure that there was mention of no blood. But we're still going to test for some of these things and get, a stool culture and biofire, and that might depend, by hospital system, what's sent on those. And so I think that's always then what additional side specific testing do you need to send? I think is sometimes going to be system specific for specific organisms, because we are going to think about some of the things that maybe are more subacute might be more the parasitic type infections and things like that sometimes you send over in parasite or specific testing for, just getting into the stool study conversation. If we're more in like the chronic diarrhea paradigm, which I think we have to think about, things that can help differentiate. I mean, this is, you know, with his age, and it doesn't necessarily have all the feature characteristics of IBD, but something that has to be on our differential, and like a fecal calprotectin might be helpful, and that really helps differentiate IBD versus IBS in terms of like inflammatory, specifically IBD inflammatory rather than infectious inflammatory state. And so that might be something that's helpful in this patient, because again, this has been going on for years, not just 3 weeks. And so is this an acute flare of a chronic disease process? But those are some of my initial thoughts here.
Yeah, thank you so much for this outstanding breakdown. Now that we're already, you know, talking about some of the next steps that we're gonna take, I think I would be curious to talk a little bit about the management of this patient, because we have a lot of clues that this patient is dehydrated, not only in terms of their history, but also on physical exam. And we love to talk about fluids on on the clinical problem solvers. And I think I would be just interested in how you think about fluid resuscitation in general, but in particular in this patient. Yeah.
Yeah, so I think the crux of in this patient, definitely, you know, again, we see some signs just on the, you know, just on the physical exam that there is dehydration. And so I think the crux of it, of how you know, the initial approach with then obviously, of course, you know, the severity of it will get a little bit more with his laboratory data, is can he take an oral intake right now? And it sounds like maybe not, just based on the HPI, because if they can, and they're only mildly dehydrated, you could use, you know, oral like electrolyte solutions. You don't need to jump to necessarily intravenous fluids and let them orally hydrate, even if they can't take, you know, full food or meals. They might, you know, be able to hydrate orally. It sounds like this patient might not be that patient based on just some of the HPI data we've heard, but those would be some of the more specific questions that, you know, I would ask just to help kind of suss that out. And that might require then intravenous, you know, hydration with normal saline or, you know, lactated ringers. And, you know, how much of it is going to also really be determined by his basic metabolic is going to be really helpful too, of guiding a little bit more of what his, you know, hydration and repletion status needs to be, in addition to what we've already gotten from the physical exam and his history.
Awesome. Thanks so much. So assuming this patient needs IV fluids, you mentioned LR and normal saline. Depending on what characteristics would you prefer the one over the other?
Yeah, good question. I mean, some of that, yeah, depending on like acid base status and sort of bicarbonate levels. And, you know, in terms of thinking more about lactated ringers versus normal saline, obviously his, you know, degrees of hyponatremia, like, you know, these are some of the things that might inform kind of then which fluids and which types of fluids, you know, is he not eating at all? What his glucose levels are? So these are all kind of things that would factor in, you know, obviously potassium needs and potassium repletion are all kind of things that would help inform a little bit.
Thank you so much. Olivia, we're ready.
Yes. So for his labs, he had a BMP, which was notable for sodium of 133 and a potassium of 3.3, and his glucose was 108. He also got a CBC. His white blood cell count was 6.9, and his CBC was also notable for 22% bands. He received a hepatic panel, which is unremarkable, a lipase, which is unremarkable, and also a fecal calprotectin, which is also unremarkable. He also received imaging and received a CT of the abdomen and pelvis with oral and IV contrast. And it was noted that he had mild colorectal wall thickening with mucosal hyperenhancement, which was read as colitis. He did also receive a GI PCR panel. And this was notable for Campylobacter, enteropathogenic E. coli, Shigella/enteroinvasive E. coli, Giardia, and norovirus. I'm just going to take a brief pause here because I know that was a lot of information.
All right. Do you want to jump right in?
Yeah, sure. I'll hold the PCR for last. I'll digest some of the others, and then I'll so again, kind of reaffirming, not surprised that he doesn't have, again, a systemic elevated white count. He is a little dehydrated. I think I missed what his creatinine was, but his sodium's a little low, his potassium's a little low. Was his creatinine elevated, Olivia?
No, his creatinine was
Oh,
not elevated.
okay.
It was 1.1.
Great. So a little mild dehydration, but not too severe. The fecal calprotectin, which is helpful. Again, we were talking about, this is really helpful in thinking about like IBD. Specifically, it can be negative, certainly with an infectious process, and we are seeing that there's a colitis that, and as leads us to that this is probably then an infectious colitis and not a inflammatory bowel disease, in terms of that's causing these findings on CT scan. Granted, that's not a perfect test, but it still doesn't 100% definitively ruled out IBD, but makes that and again, we were kind of thinking about, like, is this an acute flare of a chronic disease process, and did he have IBD all along? Like, makes me think less likely, given these data points, and then that this is an infectious cause. So I want to kind of say that before then I got to the PCR. The PCR doesn't necessarily mean that all of these are active infections. And so, that is certainly could have been from like prior infections, or like, he's like, shedding these, versus, an active infection would need to get then specific kind of stool, culture to show kind of active infection, because that's going to inform then potentially then management of some of these. We haven't really, like, there was never any blood in any of his diarrhea. Is that right, Olivia?
Yes, that's correct.
Right. So makes things like, some of the, particularly like the, E. coli, and I think I heard Shigella as well. Usually you'll get kind of blood in that. So it makes me think like that he's not having, because we're kind of then already thinking about management, like how do these things need to be treated? Which organisms are we worried about? Makes me think that those are less likely for active infections. And the things that are going to cause more, and those typically with some of the normal immune status, don't last 3 weeks, typically those organisms, or something like norovirus too, like doesn't typically last 3 weeks in someone with an immune competent patient, which we haven't heard any. Granted, you haven't heard results of HIV tests, but we haven't, I would still check an HIV test on this patient, even though we haven't heard any risk factors, because that would very much change how I think about the case. So then, the ones that more would cause this time course, you would think more like the Campylobacter or the Giardia would be more in the subacute time courses, even though we're not necessarily hearing the obvious risk factors about the water exposure and whatnot. Like maybe went camping one weekend, didn't remember it. I don't know, but sometimes we don't always pinpoint this. So it makes me think more likely of the organisms, those are the ones that we need to be worried about, and do more follow-up specific testing that will inform then how we manage this patient.
Yeah, thank you so much. I would have definitely wouldn't know what to do with those positive PCRs, and I love how you broke it down, and this just potentially being like past infections that are just positive on PCR. I think that's a very important point, and doing more workup to see if that's actually acute or as you mentioned, just past infections. Yeah, we're excited, Olivia, what you got next.
Yes, so moving on to some more diagnostic testing, he did receive a stool culture, and this came back as negative for Salmonella, Shigella, Shiga toxin producing E. coli O157H7, Yersinia, Aeromonas, Vibrio, and Campylobacter. It was also negative for Shiga toxin. He then also received an ova and parasites test with Giardia antigen, and this result came back as positive for the detection of the Giardia specific antigen. negative for the detection of cryptosporidium antigen. It also had moderate white blood cells. And those are all the diagnostic tests that he received.
Yeah, interesting. All right. So did we find our culprit here? What do you think?
Sounds like it's Giardia. Yeah, no, I mean, again, like, that these confirmatory, again, the antigens and stool cultures of like that, and it fits again, as I was saying, like of the ones that were positive on the PCR, the ones that could be subacute, were the Campylobacter and Giardia. So it fits with, because always when you get a positive test, you want to think back and like, does that fit with the clinical story that we're seeing, right? And sometimes there can be false positives, obviously knowing about your diagnostic tests and sort of, potentially kind of what some of the limits are. And I don't know the sensitivity and specificities of Giardia antigen on stool studies off the top of my head, but my pretest probability was high already with the data, again, the time course, what we've heard. Giardia can be a mimicker of IBS as well. And sometimes, kind of that, I don't think he's had Giardia for 3 years to be clear, so it does, the diagnosis of Giardia does fit with the history that we got. And so, I don't think then you need to go fishing for anything else. And I'll be honest, I don't remember the treatment of Giardia off the top of my head. I would have to look it up, but I would treat him for Giardia, see how he does. Obviously, if he still doesn't improve, then might need further diagnostic testing and endoscopy, colonoscopy, et cetera. But again, the pretest probably was high. Have a positive confirmatory test that makes sense with what we're hearing here.
Yeah, I don't know this sensitivity as well, but I love the point about, clinical context and how we think about this patient in general. All right, Olivia, I'm super curious to know what you did and your team.
Yes. So in the hospital, he initially received 1 liter of lactated ringers because of his dehydration. And just upon initial presentation, ceftriaxone, 2 grams IV. As some of these diagnostic tests started, they were ordered and started to come back, he was treated with metronidazole, 500 milligrams PO twice a day for 7 days. He ended up staying in the hospital for about 3 days, and during this time, his diarrhea improved to having about 1 to 2 semi-formed stools a day, and his bandemia also resolved.
Yeah, really, really interesting and probably a very common bread and butter case here, and I think a lot to learn from. Olivia, is there anything you wanted to share about this case, some of the things that you take away or learn from this case?
Yes, definitely. I think at first when his GI PCR came back with positive for multiple organisms, it was quite confusing as to what he might actually have. And I think Dr. Shaye's point that a PCR might not reflect active infection, but may reflect shedding is also very, very important to keep in mind as we're interpreting these results. Having the ovine parasites test with the Giardia antigen, which is quite sensitive and specific for Giardia, was very helpful to making the diagnosis and adequately treating him with metronidazole.
Awesome. Thank you so, so much.
Can I
Anything?
ask one quick question? Did you, after you got, I think you weren't necessarily actively on his case, but do you know after they got that test, did they go back and just ask just like where he had been and what he'd been drinking and whatnot? And did anything else reveal itself after after that test came out?
Yeah, I was also curious about that because you're correct. This was a patient that another team had seen, and I couldn't find anything in the chart, but I was also very curious presenting this case, what possible exposures he might have had that we maybe didn't ask about. For example, maybe camping or something like this, which maybe he might not consider travel, but he might nonetheless have done. So I would be really curious to go back and ask him more about his possible exposures.
Really cool. Thank you so, so much. Verity, is there anything you want learners to take away from this case? Maybe 1 or 2 highlights, for what people should take away today?
Yeah, no, I think from just since we most recently we're just talking about the diagnostic testing, I think that is a really important point of like, understanding kind of what the tests are kind of assessing for. So with like the PCR, like again, does not equate to active infection. And so I think that's a big takeaway. And I think something kind of see often of just like how to interpret those. I'll also add, hopefully I've like been demonstrating, I'm like, from the lifelong learning perspective, again, like I don't know, I know far from everything. Hopefully I know enough that you've learned something today, but also knowing what questions to ask and being like, again, we obviously practice with resources at our hand and kind of knowing the questions to ask about and what clinical questions raise, and some of the things we talked about, sensitivity and specificity for certain tests, or kind of the right antibiotic for an organism when we've kind of targeted it. And so I just wanted to kind of emphasize that, and hopefully modeling that behavior in the discussion today.
Yeah, thank you both so much. I hope that the patient is doing good now and could probably regain some of their weight. And Olivia, I just want to thank you for an outstanding case and even more fantastic presentation. And I think it was a lot of learning here. And Verity, I think this was a fantastic discussion. I learned so much. I'll definitely rewatch this session. Yeah, and I think we also had a lot of really cool comments in the chat. They were very active, and I'm super thankful for everybody who joined today. Special thanks to Masa for the outstanding teaching points that I'm reading here, and thank you, Rahul, for scribing. All right, if you have any final comments, then you may share them.
I just want to thank Olivia for presenting a great case, and again, that lent itself to a great discussion.
Yeah, I hope we see you both very soon again, and I hope you all have a wonderful rest of your day.
Thanks for having us.
Thank you all.
Bye. See you all soon.